My co-chair, Professor Jan Towers, and myself, I would like to welcome you to this very special session. It is for American Heart Association journal called Hypertension, probably very familiar to all of you. And this is run as clinical pathological conference, and our ambition is to be very similar to what you read, I am sure, every week in New England Journal of Medicine. So we're filming, but differently to them, we film it and then later publish a paper. So all of you who will take part in discussion will have a chance to contribute to the paper which will be published in Hypertension. And there is a very important person you need to know and talk to after the session. And she is at the back in red top, and that is Denise Kyo. And Denise runs Hypertension with us. And she will make a note of all discussants, including the email, so you can then be able to contribute to the final paper. So without any further ado, we would like to start from our first case and first presenter. And the case is of asymptomatic carotid artery stenosis in a hypertensive patient. And the presenter comes here from Paris in France, and it's Dr. Calvet. Please.
Good afternoon, everyone. It's really my pleasure to take part of this clinical presentation session. And of course, I would like to thank the organizing committee for inviting me, and also Professor Anna Dominicak for supporting this session. My case I'm going to present is about the management of a patient, of a hypertensive patient with an asymptomatic carotid stenosis. And as neurologists, it is a very common situation we have to cope with that always needs to be discussed, and that's exactly what we are going to do together. So this is my case. It's a 75-year-old man who had a history of hypertension for 10 years, treated with amlodipine, 5 milligrams once a day, and perindopril, 8 milligrams once a day, and his hypertension was considered as controlled. He had also treated hyperlipidemia, treated for 5 years with atorvastatin, 10 milligrams once a day. And his general practitioner wanted him to have an echodoppler of cervical and intracranial arteries as part of a systematic screening because of his vascular risk factors. As you can see, this echodoppler was done, and it showed an atherosclerotic stenosis at the site of the left bifurcation, or maybe just downstream the bifurcation, which was estimated about 70% according to NASED criteria in morphology. Regarding grade scale, the plaque was uniformly echogenic. It was a homogeneous plaque, type 4 plaque. And regarding the sonographic NASED index, we had a peak systolic velocity increase of 280. That translated to a high ratio, a high PSV ratio of 4.5. Then the hemographic data, the hemodynamic data, and morphologic data were very consistent with severe carotid stenosis, estimated about 70% according to NASED criteria. And his general practitioner had already decided to perform a CT angiography to confirm the stenosis. And indeed, the CT angiography was very consistent. It also showed a severe stenosis of the bifurcation, a little calcified, and just above the bifurcation, and also estimated using CT angiography to be about 70%. Then we had two consistent investigation, echodoppler ultrasound, CT angiography with severe stenosis in asymptomatic patients. Indeed, the patient had really no previous history of cerebrovascular disease, and his neurological examination was normal. his blood pressure was a little high, systolic blood pressure 160 and diastolic blood pressure 95. His recentest blood sample showed LDL cholesterol below 1 gram per liter, and his glomerular filtration rate was normal. Then maybe to start the discussion, I would like to conduct a kind of survey and to start with the first quiz. The first question is about the risk of ischemic stroke in these patients. What do you think about this risk? Maybe we can vote by a show of hands. Do you think that the risk of ischemic stroke, of course ipsilateral to the stenosis, is less than 1% per year, or between 1 and 2 per year, more than 2 per year, less than 5? Yeah, or more than 5% per year? Okay, so there's really a division of opinion. Response A, maybe it was only 1, 2. Okay, really a division of opinion. It's important because we are going to discuss about the need for revascularization. We are going to discuss this concern. We think that this patient may justify a prophylactic revascularization. We think that revascularization is needed. Nobody? Nobody? See, one person. Okay, so only 1 person, 2 person, 3, 4. Okay, it changed. Okay, any of you think that the revascularization should be performed using surgery? Or using stenting? Yeah, a lot of stenting also. And so we think that no revascularization is needed. Almost all. Maybe some of you are not sure. Yeah. Okay, so we are going to discuss these two main concerns. Okay, and it's really a huge concern. For example, in France, I remind you the population is estimated about 60 million people. And from a recent population census, we have estimated that almost 1 million French people have an asymptomatic carotid stenosis of 50% or more. Of course, not all are aware of this condition, but you can imagine the concern. So what do we know about the need for revascularization in patients with an asymptomatic carotid stenosis? We have 2 randomized clinical trials conducted in the 19th. The first was ACAS. It was conducted in North America, and it found that in addition to medical treatment, the surgery, the revascularization performed by surgery, reduces the risk of ischemic stroke, of ipsilateral ischemic stroke, from 11% in patients treated medically to 5.1% in those treated by surgery, including, of course, the periprocedural risk of stroke or death. And that translated to a relative reduction of about 50%. And in Europe, we had the ACST trial conducted in Europe, but mainly in the UK, which found similar results with similar kind of curves. And you can see that the 5-year absolute reduction was about 5%, with the benefit of the intervention which sustained beyond the first 5 years. Then we have both procedures that conclude, both studies that conclude that the revascularization, in addition to medical treatment, is effective in reducing the risk of ipsilateral stroke. However, despite a level 1 evidence for intervention, we had 2 randomized clinical trials with similar conclusion. There is really a large variation of practice worldwide. You can see on this line the VascuNet, which is a very large registry from Europe and Australia, performing patients with revascularization for an asymptomatic carotid stenosis. So most of them were treated using surgery, and the graph shows the proportion of patients revascularized for an asymptomatic carotid stenosis. It's not the proportion of patients with stenosis revascularized, but the proportion of patients with an asymptomatic stenosis among those who were treated. And we can see that the proportion range from only 0% in Denmark, no patient with an asymptomatic stenosis are revascularized in Denmark at this time, to only 17% in the UK, up to 70% in Italy, and this proportion reached 90% in the United States. We do not have published data in France, but probably we have a similar proportion of patients revascularized with an asymptomatic carotid stenosis. So why such variations? Maybe you have some explanation for that, probably a lot. But one, probably is that this procedure has questioned a lot because of the low risk of ischemic stroke in patients treated medically. Indeed, we have a great relative risk reduction, about 50%, but we have a low absolute risk of ischemic stroke. So we have a low absolute risk reduction confirmed by surgery. And the absolute risk reduction is only 1% per year. And this translates into a number needed to treat, to a number needed to revascularize, to prevent one stroke in 1 year of about 100 patients. To put it another way, 60 strokes are prevented at 5 years for every 1,000 patients treated with surgery. For comparison, in patients with symptomatic carotid stenosis, we only need to revascularize 10 patients to avoid 1 stroke in 1 year. And in patients in AF, we only need to give anticoagulant to 30 patients to avoid 1 stroke in 1 year. Then it can also be translated into the fact that about 94% of procedures are ultimately can be considered as unnecessary. And some have calculated that these unnecessary procedures in the United States cost about $2 billion each year to US care providers. And we have also to bear in mind the low population attributable risk. Indeed, if we could treat all carotid stenosis, we could only prevent not more than 4% of all strokes. So for neurologists, that's not the only concern. And the controversy has intensified recently due to growing evidence that thanks to medical advances in treatment for prevention of vascular risk factor, the risk of ischemic stroke in patients with asymptomatic carotid stenosis has declined significantly during the last 20 years. And it has declined by about 60% since the ACAS published their result in 1995. Even in the randomized clinical trial, we observed that decline because in ACAS, at the beginning, the ipsilateral risk of stroke was about 2.2% in patients treated medically, and it has declined by about 2/3. And in ACST, in the second 5-year period of ACST, the ipsilateral stroke risk was only 0.7%. Then it is currently uncertain whether the benefits, the potential benefit of carotid surgery, of carotid stenting, still justify the peri-procedural risk of stroke or death. Even so, it's right that the risk of procedural stroke or death has also declined in the same period from probably 2 or 3% to no more than 1.5%. And recently, we have also a recentless cohort of patients with recent optimal medical treatment and a meta-analysis which showed that the risk of patients with asymptomatic carotid stenosis, the risk of ipsilateral stroke is no more than 0.5%. So it's currently very low. Then, of course, we have to have a look on the medical treatment of the best medical treatment. What can be the best medical treatment? And it's interesting to have a look of what happened in ACST. The CST conducted in the 19th, but up to the last years. At the beginning of ACST, the proportion of patients who received an anti-hypertensive drug was not more than 50%, but at the end of the study, the proportion of patients who had an antihypertensive drug reached almost 90%. Of course, in that period, we observed blood pressure decreased. But probably the the main change is the use of lipid-lowering therapy. Indeed, at the beginning of HCST, less than 10% of patients received the lipid-lowering therapy, and this proportion rose to more than 80% at the end of the study. So, of course, the relative effect did not differ in patients receiving or not a lipid-lowering therapy, but at the absolute risk differ, the benefit of surgery was lower in patients receiving lipid-lowering therapy. And you can see that in patients who were not treated, the rate of ipsilateral stroke was only 1.3% in those receiving a lipid-lowering therapy, but it was 3.3% in those not receiving a lipid-lowering therapy. Also, in the randomized clinical trials, in the large randomized clinical trials, for example, in the heart protection study or in Sparkle, we know that the statin reduces the risk of ischemic stroke by about 1/3, but it also halves the number of patients requiring a revascularization in that trials. Probably there is something to do with the stability of the plaque. And to conclude on the statin effect, maybe we can detail a little this study. It was a large study which included more than 600 patients. They were seen in a atherosclerotic clinic during a long period, during a 20-year period, and they were followed up with regular Doppler examination. And they identified more than 300 patients with a progression up to occlusion. And interestingly, almost 80% of occlusion occurred before 2002, so before the era of statin. So we have to discuss the revascularization maybe, and maybe have a look on the guidelines. Maybe just read the guidelines on, for now on the revascularization. It is reasonable to consider performing a carotid endarterectomy in asymptomatic patients who have a 50% or more stenosis of the internal carotid artery. That's exactly what we are doing. If the risk of perioperative stroke, myocardial infarction, and death is low, below 3%, of course, but however, its effectiveness compared with contemporary best medical management alone is not well established. Yeah, it's not well established, but not established at all. That's really the current concern. So what to do in 2016? Maybe we can try to simulate some scenarios. If we took into account an ipsilateral stroke risk of 2% per year, as found at the time of randomized clinical trials, and this is a great dotted line, and if we consider the low risk of periprocedural complication found in CREST, recently published in CREST, only 1.4%, and after a very small risk thereafter, of course, if we took into account this hypothesis, the surgery or the revascularization would be highly effective. But if we took into account only a 0.7% risk of ischemic stroke, as found at the end of ACST follow-up, the number of ipsilateral stroke avoided for every 1,000 carotid endarterectomy performed would be only 5 at 5 years. It increased only to 24 stroke avoided at 10 years. But if we took into account a smaller risk, as 0.5%, as currently found in cohort of patients, we would cause 5 stroke at 5 years by revascularizing patients. But we have to bear in mind that this hypothesis. And I've only talked about carotid surgery, because if we took into account carotid stenting with the same result reported in CREST, so a small procedural risk, only 2.5% in CREST, but the risk is too high, and we can see that we would cause stroke at 5 years, about 15 or 25 according to the medical hypothesis. So that's something we have to bear in mind. So have you changed your mind regarding the need for revascularization? Who would recommend revascularization for our patients?
I
maybe
think
less.
you won.
One? Yeah. So no revascularization. We think no revascularization is needed. You have changed, some have changed your mind, and maybe some doesn't know if revascularization is needed. Okay. Of course, it's really, we do not compare the revascularization with medical treatment. We compare the optimal medical treatment plus revascularization to the optimal medical treatment. So it's really important, if we decide not to treat the patient, that to be sure that he is under the best medical treatment. We have a few guidelines. This one, patient with asymptomatic carotid stenosis should be prescribed daily aspirin and statin. Of course, that's consistent. And patients should also be screened for other treatable risk factors for stroke, and appropriate medical therapies and lifestyle changes should be instituted. So of course, we have to be sure that the best medical treatment is given. And we have some guidelines specifically regarding the medical treatment. For example, for antihypertensive treatment, it is recommended to treat, of course, to maintain a blood pressure less than 140/90, so not a specific target, maybe accepted if we have a very, very severe stenosis with subocclusion or a patient with associated intracranial stenosis. There is no good reason to change this simple target. So I remember that our patient was already treated using perindopril and amlodipine. So as neurologists, we don't know what to do in that condition, if it's better to add a third antihypertensive drug or to increase the dose of one. Maybe it's worth discussing because I don't know what to do. I ask you what to do in that case. What is best, to add a third molecule or to diuretic? Okay, there's consensus to add a diuretic. Okay, that's what we should do. And of course, patients, as we have already said, who smoke should be advised to quit and to offer cessation intervention. And regarding hyperlipidemia, a treatment with statin is recommended for all patients. To lower LDL cholesterol less than 1 gram per liter is a strong target. And I remind you that most of these patients are asymptomatic, had no previous history, of course. And another target is recommended if in case of diabetes with a 0.7 target. And of course, if the goal are not achieved, it's recommended to intensify therapy. Of course, diet, exercise is recommended, and glucose-lowering drugs in case of diabetes. But it's not clear whether it's needed to really intensify or not. That is not really known if very strict control of diabetes is useful. And of course, do not forget to add aspirin if the patient did not have aspirin before. Then what we could do, it depends on where you live, we could consider to enroll the patient in one ongoing randomized clinical trials. In North America, currently there are two studies that assess whether optimal medical treatment, the current optimal medical treatment, is as effective as revascularization. So in the US, you could enroll the patient in CREST-2. In Germany, you could have enrolled the patient in SPACE-2, but SPACE has just stopped because of a slow recruitment. In the UK, probably consider enrollment in ECST2. And in Russia, I don't know if there are people from Russia, but there is also a trial in Russia. The name is AMTEC. I don't know a lot on AMTEC, but it's the same kind of trials. So maybe there's another option. Maybe you would like to have additional investigation to better know about the potential risk of ischemic stroke. We will be happy to have additional investigations for these patients. Yeah. Okay, maybe assessment of cerebral vasoreactivity. Yes, one person, or potential detection of microembolism signal. Yeah, a lot. Would you be happy to have some data on the plaque structure itself? Yeah. Or other maybe, I don't know if, yeah, what would you be happy to do?
So I'm Gianpaolo Rossi from University of Padua, Italy. Among the tests that I would like to have there are at least two. Having in mind that this plaque is a sign of atherosclerosis, which could be elsewhere. Many years ago, 1994, we reported that patients with atherosclerotic renovascular hypertension had an excess rate of carotid plaques. And the same applies to coronary artery disease. So in the evaluation of the patient, I think you need to look at more than just one vascular bed. The other thing that I would like to see is that you stated that this patient was asymptomatic. And that's kind of scaring to me because symptoms cannot tell the whole story. If you do, for example, an MR of the brain, you might see signals of previous ischemic events that were totally asymptomatic. And in that case, I wonder if the definition of asymptomatic is still really there.
Okay, so these are very good points,
Yeah.
and we would like some answers to those, yeah? I've just been reminded by Professor Laurent very rightly that we have plenty of time, so don't panic. We have an hour for each case, which is very good, but we would like to have audience involvement because that's how this feels the best. Okay, so could we tackle all these points from Professor Rossi?
Yeah, regarding what a patient symptomatic or not is, it refers to clinical symptoms and did the patient have a stroke or not. A stroke means you have a symptom of a stroke. But of course, many of these patients have a silent infarct, some of them. It was my last slide, maybe I can try to show you. Sorry. And we have some study that use CT to try to assess silent infarct in that kind of patients. I chose this study because it enrolled a large number of patients, almost 1,000 patients with asymptomatic carotid stenosis, and they found silent infarct on many of them. And it's very interesting to see that the rate of ischemic stroke in that patient with silent infarct was quite high, 3.6 per year, compared with those with no silent infarct, which was very low, 1 per year. Now, probably at the patient level, that's something that can be used, but the concern that there is no real definition of an infarct on CT. So probably it's more easy using MRI, but we do not have such kind of data with MRI. That's probably something that makes sense at the patient level.
Sure.
And regarding your question about the extent of atherosclerosis, that's true that it's also a marker of atherosclerosis, and we well know that the patient with an asymptomatic carotid stenosis has a high risk of other vascular events, such as myocardial infarction. That's why the medical treatment is very useful. By revascularization, we would only avoid the stroke, the kind of stroke related to the vascular, to the stenosis. We know that in patients with asymptomatic carotid stenosis, half of stroke that occur have an alternative cause. That's why the preventive treatment is very of importance.
Okay, we have another question here from Professor Towers, my co-chair.
Thank you. Just to follow up, I guess the question that really arises at this point is, these are patients who are asymptomatic by definition, yet the GP has undergone all these tests. I think the question that I would like to ask is, who do we screen, when do we screen, and should we screen? Mm-hmm. Because surely this is what is absolutely fundamental for all these patients who are apparently asymptomatic.
Yeah, and before you answer this, could I add to this, in your huge variety between the way various European countries treat these patients, this is very, very interesting, but I wonder if you have, or somebody has the data, whether the primary referral is to surgeons or physicians, because I think the level of activity, of aggression, very much depends, you know, how aggressive the treatment is, very much depends whether it's physician or surgeon. And I know that in United Kingdom, vast majority of these patients would be with physician and never see the surgeon, and that's why it's below 18%, and that's good. Whilst in US, I presume, and maybe in France, they all go to vascular surgeon, and then the aggressive treatment follows, because we know surgeons like to use the knife and be more aggressive. So I think it would be extremely interesting to know where they referred for specialist care. This is not the first referral, but the second or third referral center. Is that known in these studies?
No, it's not well known. Of course, it's.
But I think we have an opportunity as European Society of Hypertension to maybe mount such a study, because I think it would be interesting. It could be a simple questionnaire to our ESH centers of excellence, perhaps, how, you know, what is the referral pattern depending to type of aggressiveness of treatment. I think it would be very interesting. So now you can tackle Rianne's questions.
So, yeah.
Do you remember?
Screening.
Yeah,
Screening.
yeah, about the screening. The issue is that still doesn't know if revascularization is needed or not. So I would be happy to screen patients for this if I was sure that is interesting to screen, because I would have something to do. So far as we do not really know, not sure the screening can be recommended, and it's not currently recommended. But I'm going to tell you just after that I would be happy to know, because we have ongoing trials on this topic, and we need to know the real answer. So to know the answer, we need patients, to enroll patients in randomized trial, to early know what to do. But the screening, there is no real guidelines for screen patients for asymptomatic, as we don't know what to do when they are when they have asymptomatic stenosis. So.
So any of this, do you want to ask the audience all these questions, or we've already worked on this, so we can move to next slide or quiz? Oh, there is a question at the microphone on our right. Yeah.
I have a question. Basically, the point you're taking is drugs can do very good, but problem is that we have all other stations telling patients don't take drugs. So the study shows that if you follow the patients and give them the good drugs, then basically maybe we don't need revascularizations, but in the real life, patients are lost to follow up, and so are there any studies that just looked at that?
Yeah, of course, but the data we have so far refers to patients treated with medical treatment. I don't know if they have really this medical treatment or not, but this is a risk we observe in patients with prescribed anti-hypertensive drug or statin. Probably not all are very compliant with that, but that we observe even in cohort study. In the randomized clinical trial, we don't know exactly to what extent the patient had his treatment or not, but that means a patient we prescribe optimal medical treatment. And one objective of the trial also is to know to what extent we can achieve the goals, of course.
So we have a Professor Laurent on the left microphone. Yeah.
Thank you, David, for this beautiful case and explanation. In my opinion, it's a little bit biased because the aging parameter seems to be lacking. Of course, 65, 75, and 85 life expectancy is different. And you are balancing perioperative and postoperative risk, around 2 to 3%, with an increased risk of cerebrovascular events depending on your age, because everything is presented as if the risk of a cerebral event was the same at 65, 75, or 85. So you are playing with different parameters. 70% are the threshold for taking a decision and starting discussion, okay, but what is the age? What is the risk according to the age and the comorbidities? Of course, you've chose very simply no other comorbidity except hypertension and cholesterol, but how will you deal with aging of the patients?
Thank you for the question. I can swear we did not decide before, because my next slide is about the the risk according to the age, and because maybe we can also try to identify which patients are more likely to benefit.
Yeah.
And of course, it has been shown that patients less than 75 or men rather than women have a greater benefit from carotid revascularization, and women and patients older than 75 do not significantly benefit from the procedure. But it's mainly a question of life expectancy. And it's sure that any condition that reduces the life expectancy may limit the potential benefit, if any. And so for that, we will need a model to predict life expectancy, and we have one. I propose one. This is a large study that assesses the factors associated with the 5-year survival following endarterectomy in patients with asymptomatic internal carotid stenosis. So exactly the kind of patient we have. And they identified different patterns of patients and different risk profile. And for example, we have a high risk profile with patients with a low survival. At 5 years, the kind of patient with major risk factors such as age, more than 80, or insulin-dependent diabetes, or dialysis dependence, or patient with a severe contralateral stenosis. That kind of patients are not likely to survive long enough to benefit from the procedure. But in contrast, those with a low risk profile, for example, for our patients, they are really expected to live long enough to potentially benefit. So of course, the life expectancy is really a critical factor in the decision making.
Okay, so we can go briefly to the right microphone and then we come back to the left microphone. Please identify yourself.
I'm Dr. Moodley from Durban in South Africa. Where I come from, there's a lot of diabetes, type 2 diabetes. So when we get this patient, we would routinely do a 2-hour glucose tolerance test. We would routinely also do CT scanning of the brain, because if we find previous lesions there, that will move us more towards intervening. And thirdly, just a comment with the salicylic acid prevention ongoing. Do you use 75, 81, 150, or 300 milligrams of salicylates in a patient like this?
Yeah, regarding diabetic patients?
Aspirin prevention, what dose do you use?
The recommend is the usual dose, I mean, between 75 up to 300 milligram.
But what's the preferred dose? Because, there's a morbidity associated with the use of
Yeah,
aspirin.
I would recommend the lower dose of aspirin.
Is there data to show that the lower dose, like 75 or 81 milligrams, is just as good as the 150 or 300?
We do not have specific data that compare the different doses of aspirin. It's true we have to give aspirin, but we have no study that have compared the different doses of aspirin in that condition. And we do not have any study that really assess the use of aspirin. So aspirin is recommended because of the vascular risk, including the myocardial infarction risk and other vascular risk, but we do not have specific data that attest to what extent the aspirin is useful. That's intuitive.
And just a final comment, with that improved study coming out recently, would you say that a patient like this here, one should go for well, we work in different units, but would you say that the LDL should be moved closer to 1.4 millimoles per liter? Or would you say we still stick at 1.8 millimoles because, it's a similar type of patient? I know there's no data there, but what would you do? Would you be more aggressive with the LDL level?
Not too aggressive. We do not know exactly what to do. So I'm not sure if we can, maybe we can recommend a very aggressive strategy in that condition.
Okay, so we into the left microphone, please.
I'm Guillaume Turc from Paris, France. Thank you for this great talk. You focused on carotid artery surgery, however, as compared to surgery, stenting was associated with a lower risk of procedural myocardial infarction in the CREST study. And don't you think that this should be taken into account?
Yeah, thank you. Yes, of course. Stenting, carotid stenting is a real option. But for example, in patients with asymptomatic carotid stenosis, the issue is to know in which patient maybe the carotid stenting can be as safe and as effective. In that kind of patient with asymptomatic carotid stenosis, the issue is to know whether revascularization as performed by surgery or by stenting is effective compared with medical treatment. But above all, it's also a question of do we include myocardial infarction in the safety in a composite safety outcome in trial. That had been done in trial for symptomatic stenosis. I have a slide on this. And for example, in CREST, that's been discussed a lot in CREST, and it's true that in CREST, the higher peri-procedural risk of stroke or death in patients treated with stenting was also partly offset by a lower risk of myocardial infarction. But as you can see, the proportion of patients with myocardial infarction during the procedural period is much higher in CREST than in European trials. So maybe that can reflect enrollment of different kind of patients with more cardiac disease, but also a different screening for myocardial infarction. And unlike European trials in CREST, the myocardial infarction do not justify clinical symptoms. And about 40 patients have clinically asymptomatic MI. So we can include the myocardial infarction in safety outcome, but in that condition, we should also include asymptomatic brain infarction. And it has been well described in a sub-study of ICSS, so again in symptomatic patients, but they clearly found that patients treated with stenting had a much more higher risk of asymptomatic lesions, as you can see on MRI like this, than patients treated with surgery. And they were 5 times more likely to have an asymptomatic lesions. So we can take into account MI, but in that condition, we should also take into account asymptomatic brain infarction. And probably another factor why including MI maybe is debatable is that patients do not value stroke and MI to a similar extent. And for example, in CREST, again, they found that the stroke had a greater impact on quality of life 1 year after procedural period than MI. So it's not really the same thing to have a stroke and to have an MI, in particular if the MI is asymptomatic, if the stroke is symptomatic. So we can take both, but we have to take into account symptomatic event only, I think.
Okay, so we have Professor Gary Jennings from Melbourne, Australia, on the left microphone.
Thank you. I'd like to add some support for medical therapy along 2 lines. Number one is most of the data we've talked about, it relates to rates of ipsilateral stroke, and you've already talked about the fact that quite often these people go on to have myocardial infarction. They also have contralateral stroke quite often too, and that kind of takes away the argument for local treatment of a systemic disease. My second point is we've kind of gone along with the idea, with the logic that if somebody's got, with an asymptomatic disease, has got MRI lesions of previous involvement, that leads you towards being more likely to want to intervene. But if you really believe that contemporary medical therapy works, there could be just as much an argument for that as being a useful strategy for preventing future strokes.
Yes, of course, that's why we have to use the optimal medical treatment with or without surgery, and we do not compare surgery with optimal medical treatment. The optimal medical treatment should also be given in patients treated with surgery. I focus on ipsilateral stroke, that kind of stroke that we can try to avoid with surgery. Of course, we won't be able to avoid a contralateral stroke using a carotid surgery, contralateral. But that's what we try to avoid. And this kind of patients, the higher risk is ipsilateral through the stenosis, of course.
Okay, that's great. We have on the right microphone Professor Tom Guzik from Glasgow.
Discussing the sort of procedural complications, I think the point raised by Professor Laurent regarding age is a very important aspect, and I think it's worth commenting. But I came here to ask about additional investigations that your list did not contain serial ultrasound testing for progression of the disease. What do you think is the place for that in such patients?
Yeah. Of course, there's a place for that. And it has been done in ACST, so the UK trial, because patients who were not treated were followed up using echodoppler ultrasound, and they found that patients with severe and rapid progression had a higher risk of ipsilateral stroke. So rapid means within 1 year, and severe means that really a real progression. So they had a lot of categories in the study, and when patients script one category, they were associated with an increased risk. Patients with script one category were 4 times more likely to have an ipsilateral stroke. So it's a huge predictive factor, but in practice, very few patients have that kind of severe and rapid progression.
Yeah, and how often would you think? When would the next, once we started screening, when would you do the second test in this patient?
Probably at least once a year. At least once a year.
Okay, that's great. And we have another question on the left microphone.
Yes, Grzegorz Bilov from Milan. My first question was already anticipated. My second question was, what about the cases which are maybe not so common, but you can see them of bilateral stenosis? Does it influence your management if you find in the second artery a moderate or a severe stenosis?
Yeah. Contralateral stenosis or occlusion, it's a predictive factor of a higher risk of procedural risk, but also, of course, of ipsilateral stroke. And maybe you have seen that this is a major risk factor also for life expectancy. Then that kind of patient have a higher risk of dying before the end of the follow-up in the study. So we have also to consider why this patient have a severe atherosclerosis, and maybe it also refers to a higher risk of vascular disease, and this in the same time a risk factor for stroke, but also at the same time for a vascular risk of vascular event such as vascular death.
Okay, and there is another question on the left microphone, please.
Thank you, Dr. Bargu from Paris. I have a question about the use of anticoagulants in this condition. When we have an important plaque on the carotid artery and with microembolic signals on the MRI, should it be recommended to use anticoagulant drugs to replace antiaggregants? And the second question would be about the blood pressure targets. You say that we should be below 140 over 90 millimeters of mercury, but many studies show that in the outcome stroke, the lower is the better in many studies. So should we not target less than 130 over 85 millimeter mercury, and should we not provide treatment by diuretics like other person in the this room say? Thank you.
Yeah, thank you. Yeah, I agree. The lower is the better, provided we do not have too severe stenosis. But again, I think there is no reason why we should give a different target for that kind of patients, except in those with hypoperfusion to very severe intracranial lesions. So I think we have to intensify therapy, maybe using diuretics if needed in that kind of patients. And regarding microembolic signal MRI, I did not show this slide, but on using, the microembolic signal is very, very useful, and it can also identify a subset of patients who have a very, very high risk of ipsilateral stroke. And in this large study, you can see that the increased risk was high with odds ratio, about 5/3 in patients with at least only one microembolic signal compared with those without. And it's very consistent with the meta-analysis. We've found consistent data. And it's very, very specific. And it's circulating emboli, short direction with a high intensity microembolic signal. And it's really accompanied by a shopping sound. Maybe we can try to listen. Yeah, it's okay. Yeah, it's very specific sound. And when you have this kind of microembolic signal, you have identified a patient with a very high risk of ipsilateral stroke. Then maybe we can consider this predictive factor, but nobody has shown that if you revascularize that kind of patient, you have a benefit. But it's probably in that kind of patient that something can be proposed.
Okay. Sorry, we need you at the microphone because otherwise we won't
about
capture
the anticoagulants.
the question. Let him ask his question.
The question was about the use of anticoagulants in this kind of patients?
Anticoagulant, sorry. There is no data that can recommend anticoagulant in that kind of patients. There was one study that used dual antiplatelet therapy that found that in patients, for example, with microembolic signal, patients treated with aspirin and clopidogrel had a lower proportion of microembolic signal than those treated only with aspirin. But we do not have any data regarding the risk because that kind of study was conducted in patients with symptomatic stenosis, so they were revascularized shortly.
Okay, and another question on the left microphone.
Yoni Sharabi from Tel Aviv. So we made the progress. We look at age, the comorbidities, the progression of the plaque, but I was wondering how much emphasis do you put on the plaque itself? For example, the PLOS talked about, meta-analysis talked about carotid distensibility, how it adds to the risk stratification. Do you put a lot of weight on the structure, distensibility, the plaque itself in decision making?
Yeah, of course, yes. The plaque itself, we can try to assess the plaque structure itself. It's not easy in routine, as you can imagine, but that can be done using MRI. And now using MRI, of course, we can have the severity of the narrowing using contrast, magnetic, and geography. But we can also try to have assessment of the plaque itself. And it's well known, we have a meta-analysis, 7 study, almost 700 patients. It was found, including patients with asymptomatic stenosis, that when you can identify, for example, hemorrhage within the plaque, it's a great predictive factor of ipsilateral stroke. Again, that does not mean that this patient needs to be revascularized, but that patient have a higher risk of ischemic stroke. And for other potential predictive factor, of course, at the patient level, everything needs to be taken into account, but in that condition, if we have to decide if the patient needs or not being revascularized, probably we should focus on the stenosis itself, because that's what we can remove.
Okay, Rian.
Yes. Thank you. Just going back to the question about the aspirin, do you have any comments regarding blood pressure control and the initiation of aspirin usage? Because there are some guidelines in terms of using aspirin only when blood pressure is actually controlled. So in this patient where you've still got very high blood pressure, would you still start aspirin?
Yeah, I think that we do not have really data to justify that, but it's sure that aspirin is recommended, again, not only for the plaque itself, but for the vascular risk in general. And regarding blood pressure, also we have to achieve a better target as recommended, but you have seen it's a very general guidelines. We don't have specific data specifically on this patient, so it's quite hard to directly answer the question.
Okay, so I would like to come back to the patient, patient you described, and ask you what precisely happened to this particular patient. So what have you done and what's been the outcome as far as we know with this particular patient? That's my question 1. And my question 2, which is sort of under a family and friends management type of question. How many times would you normally do detailed MRI in a patient like that? Because I accept that your data are from the CT, but in 2016, I would send the patient for MRI and maybe more than once. And I would like to know what you would do to your family and friends. That's a very good test in medicine.
Okay, thank you very much for the question. I'm going to give you my proposal for these patients because we think that the times to come in France to try to implement that factor for the TCD predictive factor, that MRI parameters in a randomized clinical trial, and this is a randomized clinical trial we're going to start in France within a few weeks. And my proposal will be to enroll these patients. So, of course, if you have at least one microembolic signal, or if you have an impaired cerebrovascular reserve, or if you have an intraplaque hemorrhage or rapid stenosis progression. So if it's estimated at higher than average risk of ipsilateral stroke, I would be happy to enroll the patient in that trial. Mm-hmm. The objective of the trial is to, the superiority trial is to assess whether revascularization as performed by surgery in addition to optimal treatment is effective in reducing the risk of ipsilateral stroke. So for that patient, we are going to assess all the potential predictive factors. If we identify at least one, I will be really happy to enroll the patient in that trial. Then regarding the second question, of course, we are performing currently MRI, and for the identification of intraoperative hemorrhage, sometimes it's needed to have a high-resolution MRI with that justify high expertise. But now it's probably possible to identify intraoperative hemorrhage in the same time of the contrast-induced magnetic resonance angiography, which is done routinely. So for my friend or for my patients, I would recommend to try to do a TCD. A TCD is widely available. It's quite inexpensive, and we can know if the cerebrovascular reserve is decreased or not. We can know if the patient has microembolic signal. And with the MRI or the MRA, which is can be done routinely, I will have a lot of data to decide.
Okay, that's very good. I think there is a question, one at the right, or two at the right, but first the right microphone, first person, and then we go to the left, right?
In the protocol and also for the patient, so what is rapid stenosis progression? Because you say we have to...
Yeah, rapid means within 1 year. It's what has been done in ACST. So, what is recommended, if you don't treat the patient, it's recommended to have a follow-up using echo Doppler, ultrasound, and so at least once a year to be able to identify a patient with a rapid progression. And the severe means really, as I've shown you before, if the patient have a rapid increase, for example, less than 50% up to more than 70, or between 50 and 70 up to 90. So we need a severe and rapid progression.
Okay, so the left microphone.
I have two questions regarding this study. Which proportion of patients with severe carotid stenosis do you expect to be eligible for this study? That's the first question, of course.
We have 3 minutes till the end of this case, so we want quick questions, fast answers, right?
Quick answer, probably about 20% of patients, but we do not know if these all predictive factors are independently associated or not. We just know that microembolic signal and intraoperative hemorrhage were independently associated with an increased risk in patients with symptomatic stenosis, or probably it would be the same thing for asymptomatic. But for the other, I don't know, probably a rapid progression is probably associated with intraoperative hemorrhage, but I don't know, but it's possible. But probably microembolic signal and intraoperative hemorrhage are really two additional interesting predictive factors.
Okay, we have only time for one more question. The lady at the right microphone. I'm afraid the rest in the break over coffee. Please.
Yes, in this study, do you take into account echographic parameters of the plaque, like hypoechogenic characteristic?
Not directly for eligibility of patients, probably in an ancillary study. Of course, at the patient level, it's really of interest, and for the decision making, it's useful if you have a very heterogeneous plaque. The issue is the definition of an homogeneous or heterogeneous plaque. Not all people agree with the same definition, so in a trial, that's not very easy to use this parameter, but at the patient level, that's something that can be taken into account.
Great. I think this completes this case. We're very grateful to the presenter. I think this was very stimulating. The discussion was great. We also thank all discussants, and please give your names to Denise, because a paper in hypertension is a valuable addition to your CV. So thank you very much, Dr. Claver.
Thank you very much.
This was very, very good.